Hi there and welcome. My name is Dr. Marlena Jabara, and I'm an American board certified podiatric radiologist. Together, we'll take a look at benign bone tumors of the foot and ankle. I or a related party have no financial relationships to disclose. Our objectives together will be to review specific principles of imaging evaluation of the most common benign bone tumors of the foot and ankle. We'll take a look at morphology, age, matrix, and location. We'll review the classification and staging of benign bone tumors, and I'll evaluate some of the more common benign bone tumors of the foot and ankle. You might remember this review of this slide. Taking a look at a bone neoplasm, we can understand that bone neoplasms can occur in certain portions of the bone, the diaphysis, which adds the length to the bone, the metaphysis, which is the zone of provisional calcification where we go from cartilage to osteocytes, and of course the physis and the end of bone, the epiphysis, or the portion of the bone that is generally having a cartilage layer and does not add length to the bone. Lesions we can identify most commonly that occur at the end of the bone: chondroblastoma, giant cell tumors, subchondral cysts, eosinophilic granuloma, all common to be at the end of the bone. Within the diaphysis, that's where we'll be seeing our round cell lesions. Those are lesions such as Ewing sarcoma as a child to myeloma as the adult. We can see lesions that are in the intramedullary portion of the diaphysis, like fibrous dysplasia. And as we move towards the metaphysis, that's a very busy area. We'll see osteosarcomas, we'll see enchondromas, and we'll notice that the giant cell tumors and aneurysmal bone cysts will even maybe related to the metaphyseal region. Again, we're going to look at different features of our patient from their age and sex, whether or not they have single or multiple lesions, what bone is involved. Is it closer to the sternum in a patient who has breast cancer? And what location, as we just denoted, is it in the diaphysis or epiphysis? Is it in the cortex? It is in the intracortical bone. Those are non-ossifying foamers. Or is it eccentric, such as a fibrous cortical defect, or is it in the intramedullary region, such as an enchondroma? What part of the bone? That will be very helpful for us to determine prospectively what we think it is. And of course, looking at the lesion itself, the morphology, the borders. Is it destroying any of the surrounding structures? Is there a periosteal reaction, matrix, and soft tissue mass? The age of the patient is extremely important. Looking at ages of patients and well-defined or versus ill-defined lesions, we can see in the 0 to 10-year-old category, eosinophilic granuloma and simple bone cysts are the most common reason to have a well-defined lesion. The ill-defined types, those are more insidious: the Ewings, the osteosarcoma, and leukemias. From 10 to 20 are young adults, have non-ossifying fibromas. We're in the lytic bubbly lesion category: osteoblastomas, fibrous dysplasia, E-gran, simple bone cysts, aneurysmal bone cysts, chondroblastomas, and even chondromyxoid fibromas. Notice the ill-defined in that category: Ewing's remains, and so does osteosarc. So there's a portion from at around 15 years old, or these adolescents can be still at risk for Ewing's and osteosarcoma and eosinophilic granuloma. From 20 to 40-year-old, we're going to be worried for a giant cell tumor once the growth plates close. So closure of the growth plates might indicate that we have a giant cell tumor. Enchondromas, chondrosarcomas, brown tumors as seen in hyperparathyroidism, all found in this age of 20 to 40, and osteoblastomas. Also very important, the ill-defined category, giant cell tumor is very popular in this particular age category. And then over 40, we're dealing with metastasis, myelomas, subchondral cysts, and if it's ill-defined, it may indicate metastasis, myeloma, and of course, chondrosarcoma high-grade versions. At all ages, the skeleton is at risk for infection, and those can be even well-defined and ill-defined, so that will always be in our differential. Moving on to sclerotic bone lesions, as divided by age, we can see the young patients, a sclerotic lesion likely to be an osteosarcoma, so we'll look out for that. 10 to 20, we can add in fibrous dysplasia, E-gran, osteoid osteomas, and osteoblastomas as additional to osteosarc. 20 to 40, what we're seeing there, enchondromas, osteomas, those are bone islands. Parosteal osteosarcs, those are lesions that occur adjacent to the cortex. parosteochondrosarc, so all these surface lesions in this particular age group, and healed lesions, healed lucent lesions that have now filled in with sclerotic bone, non-ossifying fibromas, egran, simple bone cysts, aneurysmal bone cysts, chondroblastomas, and of course, over 40, sclerotic lesions. We'll worry about sclerotic metastasis, including breast and prostate, chondrosarcomas, of course, bone islands in every category, and infection may be sclerotic. Again, just to review our patterns of bone destruction that can be very helpful as seen in these types of illustrations when we're talking about a very sharp border, a geographic lesion versus something that is beginning to have these small areas of lucency and moth-eaten pattern versus an area of more permeative pattern that's about to have an exophytic soft tissue mass in its aggressive pathway. Patterns of bone destruction, we'll be looking for that regular, benign, thick sclerotic rim. It can be lobulated, thick sclerotic rim, and if there's portions of it that we cannot actually see the edges of the border, we'll be talking about geographic, multicentric, or grade 1B. They can be poorly defined where we don't see that edge of the lesion. We can see the lower portion of the lesion, but we're missing the superior portion in these grade 1B lesion. And of course, aggressive bone lesions, moth-eaten patterns, will be on the lookout for that as aggressive features not consistent with benign lesions, whether there be moth-eaten margins here, these low lucent lesions of small 3 to 5 millimeter, and here seen with more clarity, these moth-eaten, more aggressive lesions, and our permeative patterns, seen very aggressive lesions where we're seeing very small areas of cortical and intramedullary lucency over a certain length that is affecting the cortex. Permeative pattern, very aggressive. We'll be looking for penetration of cortex. Once the cortex is penetrated, we want to ask ourselves, is this aggressive? In this case, we can see again our wonderful 1A sclerotic, very well-defined lesion consistent with a benign lesion. Now we begin to see that there's some expansility to this portion, and it is still intact. We don't see a pathologic fracture, so we'll be looking to see how much expansility, and if it's not greater than the length of the lesion, this is still on the order of something that can be benign, as something that can be seen in non-ossifying fibromas. But when we get to this portion here where we're actually seeing cortical break over the entire length of the lesion, this is aggressive. This is a grade 1C lesion, likely either going to be infection crossing the growth plate or something like an aggressive tumor. Evaluation of the bone neoplasm for bone neoplasms continues with the sclerotic rim. Is it complete or not complete? Is there portion of the rim that's complete, seen in a grade 1B, or is it where we can't figure out where is the entire lesion in something that could be a giant cell? Is the shell expanded? Is it expansile, and how much is it expanding? We can see this bubbly lucent lesion, very well defined. It's just beginning to have this expansile region here. And here we can see it's greater than 1 centimeter in width and over the course of the lesion in something that we'll want to understand, is this having some type of pathologic fracture or extension through the cortex? Looking at patterns of bone destruction takes us to our geographic versions. That's 1A, B, and C, depending on whether or not you have a complete sclerotic rim, whether it is something that is thin but still perceptible, or whether you cannot see the rim any longer. And each of these tells us something about the biologic activity. A 1A lesion may indicate it's slow growing. It's sharply outlined. There's time for the bone to react against the lesion in deep to it. Or is the lesion becoming active? If the lesion is becoming active, that's something that we want to understand on the x-ray, because we can further understand that it may be more aggressive. It may be moving towards a different phase of the biologic life of the tumor. And of course, when there is no rim around it, that is considered an aggressive lesion, and we want to further image the patient to understand exactly where is the lesion and what is it doing. Is it in a malignant process, and does it need follow-up? Bone tumors can be further graded through x-ray using the Campanacci, where grade 1 is quiescent, that well-defined rim. Grade 2 is active. That's your 1Bs. There's a well-defined margin, but it lacks sclerosis. It might be even thinning the cortex and expanding it. Or is it a grade 3 aggressive? Ill-defined margin in that case, often with cortical destruction and soft tissue extension. And of course, the Enneking stage of bone tumors says much the same. Stage 1, 2, and 3, latent, active, and aggressive lesions based on the borders that we see. In reviewing common benign tumors, I'm going to take you through a list and show you examples of many of these tumors. We'll be seeing how many of these tumors are fitting into the categories of whether they're in the diaphysis, whether they're part of the metaphysis, or whether they're part of the end of bone. So let's kick it off with an intraosseous ganglion. This is an extremely common lesion. It's often seen as a radiolucent lesion without areas of obvious degenerative arthritis. Seen here in this x-ray, we can see this lucent region at the base of the fourth metatarsal, creating some degree of endosteal scalloping. I do not see a pathologic fracture here. What this turns out to be is usually there is some type of breach where some type of synovitis between either a close area is able to decompress within the bone. So there's some type of cystic change in the soft tissue that finds its way into the medullary canal, and it's often well defined, fulfilling all the criteria of a benign bone lesion, being a thick-walled sclerotic rim. And the most common locations are often in these areas of close proximity. Here we can see our intraosseous ganglion, our lucent lesion, and of course we have a CT that can help show us where we couldn't see this area of overlapping bones, where the base of the third overlaps. We can now see that on thin section slice CT as that small area of cortical fenestration in this patient who has an intraosseous ganglion, entirely benign. And you can refer further to these lesions for further examples. Just put that right into your browser. Our example of an intraosseous ganglion can be seen here at the base of fourth metatarsal, where we're seeing on this T1 weighted image, and T1 weighted because we know that the fat within the intramedullary bone is bright. We can see that replacement of the intramedullary bone in this location, and the signal characteristics here are isointense to skeletal muscle. Notice it's hyperintense on T2 weighted images, and then on post-contrast imaging, there's very thin wall enhancement in this benign lesion consistent with an intraosseous ganglion. Moving on to a non-ossifying fibroma, this is a well-circumscribed solitary fibrous proliferation. It's intracortical. Notice that it's expanding the region of the cortex. It has this bubbly, lucid core with a thick rim of sclerosis around it, slightly expansile, no pathologic fracture. It's fulfilling all of our criteria for radiology endosteal scalloping. And the key to the diagnosis is this well-geographic pattern with this lucent lesion. It's cortically based, which is a key feature noted in this metaphyseal diaphyseal region or metadiaphyseal region, a non-ossifying fibroma. More examples of non-ossifying fibromas. Notice this is in the cortex. We have this sclerotic rim. There are areas of sclerosis within it. Let's take a look here. Another example of a non-ossifying fibroma, an intracortical lesion that's related to the eccentric portion of the distal lateral tibia, very common location. Notice here it's becoming more thin-walled, still lucent. Definitely within the cortex, as we can see, the cortical bone expands. That's a great feature. If we see that the area of the cortex is expanding, then we can put this lesion within the cortex. And I have this lesion following it through time, looking how we look in April 2002. We can see there's this intracortical lesion that we follow about 5 months later, noticing it's filling in with a greater degree of sclerosis. And still the next year to follow, we can see even greater degrees of sclerosis in the natural course of a non-ossifying fibroma. Let's take a look at an intraosseous lipoma. This is an extremely common lesion, often picked up in the fourth and fifth decades, and a fair amount of them do present with pain, 70%. 30% of them are incidental. Here's the example. Basically, we're seeing this lucent lesion at the calcaneal body with a central core of calcification. This is extremely common, and the differential diagnosis of this lesion in this location might be a unicameral bone cyst. We can go on to do imaging to determine whether there's fat or whether there's fluid in this lesion by using MRI. Another example of an intraosseous lipoma seen here at this asterisk. Take a look here at the MR features of this lesion that's in the talus. Not a common location for this, but of course I can refer you back to this wonderful lesion, this biopsy-proven mass. This is an intraosseous lipoma. Notice on T1 sagittal imaging through the ankle, there are portions of the lesion that are also elevated. So there is macroscopic globules of fat that actually on T2 weighted image have fat suppression. So notice the area of fat becomes lower in signal, and having that feature can help guide us as to what is the lesion exactly. So this is an intraosseous fat-containing lipoma lesion. Moving on to a unicameral bone cyst that can be seen in the calcaneus. Notice there's this lucent lesion, thin wall, very well defined. It's slightly thin in this location. So we have a geographic lucent lesion. Went on to do an MRI. What we can see is that there's actually fluid within the intramedullary space in this patient who has a unicameral bone cyst. Let's take a look at another example of a unicameral bone cyst published from the literature. What we can see here is that there's a lucent lesion on this lateral ankle x-ray within the calcaneal body. Here's another example of a similar lesion in the calcaneal body with areas of well-defined sclerosis surrounding no pathologic fracture. Taking a look at this lesion on the MRI, this is a elevated T2 signal bright lesion, denoting that there is a fluid intensity within the lesion and not comprised of fat, unicameral bone cyst. Moving on to aneurysmal bone cysts, this is the epidemiology. Usually less than 20 years of age is where these cases present. The presentation can be a dull, insidious ache to an acute pain, and many of them are primary, but up to a third of aneurysmal bone cysts are actually associated with another tumor, something like a chondroblastoma or a fibrous dysplasia, giant cell tumor, osteosarcoma. So it really goes along with many other tumors. And what we can see here, we have a few examples. We can understand there's this expansile lesion on the x-ray. You can see better on the CT. It's almost imperceptible on the x-ray that there's a thin rim of residual cortical bone. And notice on the MRI, we have this lesion that has this T1 low signal change to it, elevated T2 signal intensity. It's demonstrating some degree of post-contrast enhancement. And notice that on the axial image, there are areas of septal spaces, like cave-like spaces. And this is very typical for the aneurysmal bone cyst to have a fluid level within the lesion. That's a very common finding and helps us to make the diagnosis. Here are more examples and better seen of this finding that I'm talking about. Eccentrically, these lesions are generally located at the level of the metaphysis or a metaphyseal equivalent. They're common in the long bones and the lower limb, and they tend to occur in the tibia and fibula at 24%, in the femur about 13%, and so on. And what we're looking for, this is a very important feature. These levels that you're seeing are different levels of blood products that are occurring within the lesion that layer out and give us a strong indication that this is an aneurysmal bone cyst. You can see here. On an aneurysmal bone cyst, X-ray can be sharply defined. There can be an expansile osteolytic lesion or thin sclerotic margin. You can have the donut sign where you have increased uptake peripherally with a photopenic center when you're looking at on nuclear medicine. On MRI and CT, we're looking for fluid levels, and the differential diagnosis of when we see fluid levels means that the patient may have a giant cell tumor, a chondroblastoma, a simple bone cyst, or even telangiectatic carcinoma, because all of these lesions are noted to masquerade and go around with aneurysmal bone cysts. So if we see an ABC, we want to remove it and understand, does it have another type of tumor associated with it? So that will be the importance that the histologist will let us know if this is a secondary ABC or a primary ABC. And more examples of fluid levels from our literature. We can see that we can't really appreciate them as well on T1, but when we go to the fluid sensitive sequence, we can understand these layering regions represent fluid levels in an aneurysmal bone cyst. And our job is to get the patient to the orthopedic oncologist to understand, is there a second lesion underneath this? More examples of this aneurysmal bone cyst. What we're talking about is treating it operatively, curettaging and bone grafting, making sure that we understand the features under pathologic evaluation, analyzing whether or not there's a secondary lesion. We can then, once we have cleared the lesion, we can perform percutaneous treatments and inject fibrosing agents, and often spontaneous regression may occur, but that depends on if there's any residual tumor left behind. Osteoid osteomas represent about 10% of all benign bone lesions. This is a nocturnal pain that can be relieved with rest and salicylates, so taking aspirin often relieves the pain. This can be composed in the cortex of a nidus, a vascular core, a fibrovascular rind, and reactive sclerosis all around the lesion. When it's in the talus, it tends to be subperiosteal. A lot of these lesions, 60 to 80%, are in the long bones of the femur and the mid-tibial diaphysis. About 20% are in the phalanges, and about 10% occur in the posterior elements of the spine. Notice this MRI, this sagittal MRI, you're seeing this high-intensity T2 signal lesion within the subperiosteal region of the talar neck, inciting a fibrovascular core. Notice there's also a joint of fusion here. Osteoid osteomas, what the test of choice would be a CT so that we can really understand the degree of sclerosis. In nuclear medicine, we can see a double density sign where there's a hotter spot within the center of the lesion surrounded by a core. The MRI can be sensitive but not specific to these lesions. They can be hard to see given that they can be very small. And the treatment is radiofrequency ablation. We're going to put a radiofrequency probe right into the lesion and ablate this. The differential diagnosis of seeing something like this can appear. For example, in this case, we have an osteoid osteoma. The differential diagnosis can appear as a sclerotic lesion or patchy sclerosis as seen in Brody's. It can look like an osteoblastoma when they're smaller. Of course, a stress fracture can induce sclerosis, and a cortical desmoid may induce sclerosis, and that's something seen at the posteromedial distal femur along the knee. In this example of osteoid osteoma, we start with the x-ray where we really can't see that lucid nidus, but we can see there's a certain degree of sclerosis at the level of the posterior calcaneus. Notice on the CT jumping to the right, we can see that nidus and the surrounding sclerosis. And on MRI, we can appreciate that lucent center or that low signal T1 center and the fibrovascular enhancement surrounding this lesion and the intense sclerosis seen in this patient who has an osteoid osteoma. Osteoblastomas are considered rare, 1 to 3% of all bone tumors, having a male to female predilection of 2.5 to 1. These lesions tend to be larger, greater than 2 centimeters, and their most common location is in the spinal column, usually in the posterior elements. What we're looking at here is seen on the frontal view. We can see our vertebral body, and there's something overlying the region of the pedicle. Looking at the oblique view, we can appreciate the Scotty dog. The Scotty dog is where we can see the pars interarticularis here. This is the ear of the Scotty dog. The nose of the Scotty dog is seen here. And this pars interarticularis in this region is replaced by some type of lesion that's sclerotic and lucent, occupying this portion of the posterior element. We can see that here and also here. Osteoblastoma is better seen obviously on CAT scan. We can see that on X-ray we have this lytic lesion with reactive sclerosis, but CT is where we really can appreciate this mixed blastic lytic lesion involving the cortical elements of the posterior elements. On MRI, this is going to look like a typical low T1 pattern with an elevated T2 pattern. It looks like for all the world a malignancy. And the treatment is going to be an excision. These lesions tend to continue growing and they can encroach on the central canal if it's in the spinous processes or along the posterior elements. In the talus, I found a lesion. We have an osteoblastoma here. We can see that there is an irregularity along the subperiosteal bone, but it's much larger than we would expect for our lesions of osteoid osteoma. And this was a biopsy-proven osteoblastoma. Here we can see an osteoblastoma. This lesion is entirely replacing most of the talus. It's causing a great degree of enhancement throughout this aggressive appearing lesion in a patient who has an biopsy-proven osteoblastoma. Moving on to chondroblastomas, these are end-of-bone lesions. They're rare, less than 1% of all bone tumors. They can masquerade as secondary ABCs or with ABCs, aneurysmal bone cysts. Generally, they pop up in our early adulthood, second and third decades. And the most common location is going to be the epiphysis of a long bone. 70% of them are occurring in the humerus. 10% of them found in the hands and feet. And what we're looking at here is a subchondral lucent lesion at the end of the bone in the epiphysis of the talus. We see some more examples here of chondroblastomas in the talus. And we can see that chondroblastoma here, barely perceptible on this lateral x-ray, but notice here we have this irregular heterogeneous lesion replacing a good portion of the talus in this biopsy-proven chondroblastoma. More versions of this chondroblastoma, we can see the T1 replacement, a large lesion in the talus, demonstrating post-contrast enhancement in a patient with biopsy-proven chondroblastomas. Moving on to chondromyxoid fibromas, this is less than 1% of bone tumors. The patient may present with indolent pain. Generally, they can present without calcified matrix, look like an NOF, have eccentric features, and the treatment is going to be curettage, but recurrence is common. This is an example of a chondromyxoid fibroma identified here, creating this expansile lesion at the base of the third proximal phalanx. Another example of a chondromyxoid fibroma here with MR correlation. We can see and appreciate this lesion at the base of the second metatarsal. We can see that there is changes. It's a geographic lesion that we have normal to abnormal bone, which we identify. We might think that this is similar to our first case of an intraosseous ganglion, but when we do the MRI and we get the post-contrast features, we see a very thick wall rim in this coronal T1 image, demonstrating the enhancement pattern all around this lesion. And in the central region here, notice this irregular T1 pre-contrast enhancement and the post-contrast enhancing rim. The fact that theirs is not thin and regular is suspicious and will require a resection to prove what is the actual tissue in this lesion. Here's another example of a chondromyxoid fibroma. They can have many different appearances. Many of them are lucent within the cortex. And when we do post-contrast imaging, we can understand how some of these lesions are going to have that thick wall enhancement. So we want to, of course, work these up with an MRI. Enchondromas, extremely common. Solitary lesions. We can see them multiple in the younger age categories in certain types of multiple chondromatoses patterns. Calcifications can occur except when they're in the phalanges. When they're in the phalanges, we don't always see mineralization, and that's okay. If we're thinking about multiple versions, the Olieres having multiple enchondromas, or Maffucci's having multiple enchondromas and hemangiomas may indicate Maffucci's. And this is essentially, we're looking at ectopic hyaline cartilage rests within the lesion. They can be central, intramedullary, and about 50% of these solitary enchondromas are occurring in the hands and feet. The metaphysis is the most common location. And we can see here in the toe, we see this expansile lesion, this lucent lesion, very common to have it in the toes, the small bones of the hands and feet. Notice the associated pathologic fracture in this lesion here. This is a child. This lesion is in a skeletally immature patient where we're seeing the growth plate. So of course, we're going to want to stabilize this lesion. When we assess this, we will curettage, send the samples for histology, and then pack the lesion. The pathologic fracture shows indication for surgery. Of course, we can see that we can barely see this lesion here. Notice on MRI, we're seeing this low signal lesion replacing the base of the third proximal phalanx. And of course, elevated T2 signal intensity in this biopsy-proven enchondroma. The spectrum of enchondroma can be very variable. Let's remind ourselves that cartilage can be stippled, it can be flocculent, and it can move on to rings and arcs. So the stippled variant may be a very difficult variant to see that there actually is some type of chondroid matrix, but these are the three versions of this chondroid matrix. Here we're seeing an enchondroma pathologic fracture. Here we're seeing more of the ring and arc version, and here we can see it on MRI very well defined. And using our bone RADS category, we're going to be able to assess this further, assessing the degree of endosteal involvement. And if it's going to be less than 5 centimeters, fulfilling all the criteria for an enchondroma, we're going to term that out as benign enchondroma, no further follow-up. If it does not fulfill those criteria, then we're going to go on to have follow-up, where we're going to look at the patient at 6 months, 12 months, 18 months, and 24 months to establish a series of stability. the spectrum of enchondroma on cross-sectional advanced imaging. We can see here on this axial image through the distal femur, we're seeing the ring and arc sort of configuration of the chondroid matrix. And of course, on CT, we can see that matrix with greater clarity. Enchondromas, if they're going to be multiple Olliers, multiple enchondromatosis, what we find in these patients is that the cartilage cap or the cartilage that can be associated with these enchondromas may give rise to greater degrees of malignancy. So we will be following our patients that have multiple enchondromas yearly and bi-yearly to understand, are there any new areas of pain developing? And patients often have multiple areas like this. Here we're looking at a lesion at the fourth finger. We're looking at the fourth metacarpal, this expansile lesion, more different types, not only enchondromas, but osteochondromas occurring with these multiple chondroma patterns. Adding soft tissue hemangiomas to the type of syndrome gives us the diagnosis of Maffucci's, an even higher risk of malignancy because of the increased soft tissue masses. And distribution can be in the small bones of the hand and feet of over 50% of those. Large tubular bones can also be affected. In Olliers, some of these examples I have in my teaching files of multiple enchondromas, we can see these long linear cartilage rests. They're more likely to have malignant transformation, even more than the short tubular lesions, and increase with soft tissue hemangiomas, that the version of Maffucci syndrome. Osteochondromas, this is 10 to 15% of all bone tumors, 35% of benign bone tumors, and it can occur with a malignant transformation in a cartilage cap of even less than 1%, and up to 5 to 25% in patients who have hereditary multiple exostoses or multiple osteochondromas. Indications for surgery would be malignant transformation and, of course, compression of adjacent structures. So this can be an important reason to come to imaging. And here we can see in this second metatarsal, this lesion, we have an expansile lesion that's contiguous with the bone, and we can see this sessile osteochondromatous variant occurring here in this osteochondroma. And we're going to go on to do cross-sectional MR imaging to understand the degree of cartilage cap. Here, another version of an osteochondroma. These lesions are all contiguous with the medullary canal. Sometimes that can be difficult to see, so we may need to do cross-sectional imaging, but in MRI, it's best to see. What we're looking at here is the chondral cap. That's the most important part of the lesion that we're looking for to understand is there malignant potential. So here we have this cartilage cap, and there may be in areas greater than 1.5 centimeter, that would be suspicious for malignancy. An example of an osteochondroma from the literature. Here we can see this sessile lesion. It's contiguous with the medullary canal. We're going to perform the MRI to get a sense of the cartilage cap. Because this lesion was compressing adjacent structures and had a thickened cap, it was resected. Biopsy-proven osteochondroma. Similarly, I'll add in these cases of subungual exostosis to show you that underneath the nail, we can have lesions that occur that are somewhere between an osteochondroma and a reactive exostosis. And we can see that lesion may be contiguous with the cortex. And on CAT scan, we can see here this lesion, this exostosis occurring underneath the nail bed in a subungual exostosis. Looking at additional lesions of a periosteal chondroma, it can be difficult on X-ray to see these lesions that may be hiding and contiguous with the bony structures, but we can see there's some kind of sclerotic band that's formed underneath the level of the PIP joint. And on cross-sectional imaging, we can see, this is an old slide and we can review the literature here, that we have this lesion that's contiguous with the surface of the proximal phalanx and has this large cartilage lesion associated with this in this periosteal chondroma. A companion case to that can be seen with neurolesions. These are called neurolesions. They're bizarre parosteal osteochondromatous proliferations. They're felt to occur perhaps secondary to trauma occurring at the hands and feet, and we can see these bizarre osteochondromatous proliferations that are occurring on the surface of the bone. Here we can see it's nearly circumferentially encompassing it, and here we can see adjacent to this region, these are neurolesions. Looking at giant cell tumors, the general rules are these lesions do not occur unless there's a closed epiphysis. and lesions may extend to the subchondral plate and abut the articular surface in a large majority of the lesions. So 84 to 99% are coming within 1 centimeter of the articular surface, if not adjacent to it. Eccentric, if it's large, they may be difficult to assess, or they may be sharply defined with an eccentric zone of transition. So a narrow zone of transition without seeing the border against the articular surface may indicate we have a giant cell tumor. They can be difficult to see. They can be large. What we're seeing here in the posterior calcaneus, there's this lucent lesion that's replacing the entire end of bone, the posterior calcaneal tuberosity, and this is consistent with a giant cell tumor. This is non-mineralized eccentric lytic lesions. They have a large number of osteoclastic giant cells, and what we're looking for on the MRI will be complete replacement all the way to the end of the bone. The location most commonly around the knee, as in most lesions, 50 to 60%. When they're at the distal radius, 10 to 12%, these are more aggressive malignant types. And of course, sacrum and vertebral body, these lesions have been known to occur. Giant cell tumors in the ankle, we can see they, again, masquerade or run around with aneurysmal bone cysts. So if we see an ABC, we want to make sure to histologically evaluate that lesion to make sure that we're not missing an underlying giant cell tumor. Here in the talar dome, we can see replacement of this talar dome at the subchondral plate. We did a CAT scan. We can see that it nearly replaces, and there's some cortical irregularity along the medial border. Here we can see the MRI replacing the cortical bone in this subchondral, very large lesion that's at risk to fracture in this patient who has a biopsy-proven giant cell tumor. Notice it also has some fluid levels. There may be a component in this that has some features of aneurysmal bone cyst also. Giant cell tumor, in our case here, we're seeing our subarticular talar region, and we're noticing the subarticular mass, perilesional edema, aggressive features in our giant cell tumor. In summary, I provided you an imaging approach to benign bone tumors of the foot and ankle. We've reviewed some specific principles of imaging evaluation again to look at how benign tumors are spoken in terms of morphology, age, matrix, and location. And I gave an evaluation of some of the more benign bone tumors of the foot and ankle that we can encounter. Again, our list that we saw together: non-ossifying fibromas, intraosseous ganglions, intraosseous lipomas. We went through simple bone cysts, aneurysmal bone cysts, looking at osteoid osteomas and the larger version, cousin, the osteoblastoma. Looked at some chondroblastomas, rare chondromyxoid fibromas, very common enchondromas, osteochondromas, and some of the multiple hereditary syndromes such as Olier's and Maffucci's. We took a look at some variant cases of subungual exostosis and the Nora lesion, and finished up with giant cell tumor. Thank you so much for your time and attention. I appreciate sticking with this, noticing this benign sclerotic lesion that we can see here in a big benign bone island, and of course our unicameral bone cyst that we saw in the body of the calcaneus here seen on X-ray. References are available for your review.